So I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of July 16th, 2025 to order at approximately 9:03 a.m. Pacific. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Chris Lehman.
Present, and I did want to let you know, Chair Bailey, I'm having some computer issues as well, so I will not be on camera today.
Thank you for letting me know, Mr. Lehman. I will be on and off based on my technology availability as well. So thank you for making us aware.
John Murray.
Present.
We have a quorum.
Melissa, thank you. I want to also welcome everyone to today's meeting and reference that we have an American Sign Language interpreter here with us today. Please use the Zoom controls to access the interpretation channel, and I believe Melissa put those Zoom controls here up on our screen. So I would now like to move forward with any conflict of interest declarations, which are stated each month according to board policies. Do board members have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities? Have board members provided testimony to the Oregon Legislature about prescription drugs? If so, please give the committee name and date. Does anyone have their hand raised that they would like to provide any actual or real conflict of interest statements?
Chair Bailey, I'm sorry, I can't get my hand raised at the moment, but I do have a statement, please. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs, Incorporated, comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBMs, insurance companies, and the state of Oregon. Thank you.
Thank you, Mr. Murray, for that information. I too may have a difficulty on this platform seeing when hands are raised, so I will ask for support from my team navigating that. I do also want to reference for the record that this is an additional announcement related to the fact that starting on our August 20th meeting, board meetings will now start at 8 a.m. Pacific. So we've previously always met at 9 a.m. Pacific, but for the record here for everyone attending and listening today, please adjust your calendars that board meetings will start at 8 a.m. Pacific beginning Wednesday, August 20th, 2025. I do now want to ask members if anyone has any changes to draft minutes from the June 18th, 2025 meeting. And if no one has any changes to the proposed minutes, I would like to ask for a motion and a second to approve the minutes.
This is John Murray. I'll move to approve the minutes as presented.
Mr. Murray, thank you for the motion. Do we have a second?
I'll second it.
Ms. Hoagland, thank you for the second. Melissa, if you could please call roll.
Dan Hartung.
Aye.
Lori Hoagland.
Yes.
Dan Kennedy.
Abstain. Absent last meeting.
Chris Lehman.
Aye.
John Murray.
Aye.
Vice Chair Amy Burns.
Abstain.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa. I would now like to call on staff to provide us with a program update.
Good morning, everybody. My name is Alex Chang. I am the Deputy Administrator for the DCBS Division of Financial Regulation, and notably am not Ralph Magrish. I'm here to announce that Ralph has taken a different position within the division. And so I want to first thank him for his service to this board, to the work that we all are doing here. And you know, it's quite a feat to have stood up this program and get this process going. And so I just really appreciate all of his efforts. I also want to let everybody know that we are currently recruiting a replacement for the executive director position of both the PDAB program and also our drug price transparency program. The deadline to apply is July 28th. And so I encourage anybody who knows anyone who is qualified and interested in serving as executive director to go to our website and apply. I suspect it will be a pretty thorough recruitment process with several rounds of interviews. So I wouldn't expect someone to come on board until end of September, or maybe October 1st kind of time frame. But it'll depend on how many people we get and how many rounds of interviews we need to do. So wanted to provide that update. Also, I will note that the posting for the new board member position has closed. We received several candidates. We, along with the governor's office, are in the process of reviewing those candidates and vetting them. So hope to have some additional news to share in a future meeting. And with that, I will turn it over and see if any other kind of staff have any other updates that they want to share at this time. Not hearing any. I will happy to answer questions, and I see Chris Lehman has his hand raised.
Yeah, so Alex, thanks for that update. I was wondering if you can shed any light. I think Ralph had told us they were looking for physicians specifically for the applicant for the new board position. Did you have physicians who applied?
Yes, but
Okay.
we got, I will say we got a pretty diverse applicant pool in terms of people who applied. So, I think we're going to consider everybody.
Well, yeah, and for the record, I just want to reinforce that, sorry, some technology problems on my end. Can someone confirm that you can please hear me?
Yes, we can
Yes,
hear
we
you.
can hear you.
Thank you for confirming. I do just, for the record, Mr. Lehman, want to reinforce what Director Chang referenced, that anyone that met the statutory requirements of being eligible for a board member, they were encouraged to apply in our previous meeting. And we just reinforced that we follow our statute related to eligibility for PDAB members.
Okay, if there's no other questions, I'll turn things back over to Chair Bailey.
Thank you. So I want to reference that we do have one public comment period on the agenda today for all comments. The board received 11 general written comments, which we have reviewed and posted on the board website. Those written comments were provided by Melissa Horn from the Arthritis Foundation, Robert Popivin from GHLF Pioneer, Harry Giwanter from Let My Doctor Decide Action Network, Robert Popivin from GHLF Pioneer, Carissa Kemp from Sanofi, Bill Head from Pharmaceutical Care Management Association, Anne Marie Bristermeyer Squibb, Tiffany Western Robertson from Ensuring Access Through Collaborative Health Each, Lauren Sant, Caring Ambassadors Program, Jessica McBride, Oregon Coalition for Affordable Prescriptions, and from Brian Mayo, Oregon State Pharmacy Association. With that said, the board also received 6 requests to speak. I will call on those who signed up to speak and ask them to state their name and organization. Each have 3 minutes to speak. The board will not deliberate on issues or requests during that time. Want to reference that first individual on my list here is Rainier Simmons from the Community Access National Network. Rainier, if you are here, welcome. And as a reminder, you have the floor and you have 3 minutes. Melissa, can we confirm if Rainier is in attendance?
Hello, good morning. Can you hear me?
Oh, we can hear you. Welcome.
Okay, sorry, I am also having technical difficulty today. Good morning. I'm Rainier Simons, and I'm speaking on behalf of CAN Community Access National Network today. Thank you for officially removing Odefsey from the list of medications selected for affordability review. We would also like to thank Chair Bailey for highlighting the affordability mechanisms of HIV antiretrovirals, including but not limited to the State AIDS and Drug Assistance Program. Regarding the affordability reviews, we are concerned about the number of reviews slated to be conducted per meeting. We appreciate the board's desire to fulfill a specified number of reviews by a specified timeline as described by statute. However, it would be more impactful to review a smaller number of drugs to allow a more thorough and impactful analysis. Taking the time to do a more exhaustive analysis of fewer drugs would enable the formation of an effective process of defining and determining affordability for patients and the system. Establishing an evidence-based process now would facilitate efficient reviews of drugs reviews in the future. Without a thorough established review process, allowing sufficient time for effective discourse analysis, the board runs the risk of decisions being viewed as arbitrary and capricious. Drugs selected for review and the affordability review process must conform to written policies of selection and a replicable process for determining cost impact and affordability. We appreciate all of your ongoing thoughtful and deliberate discourse. Thank you for your time today.
My apologies, I'm on a new device. So thank you for providing the feedback to our board today. Next individual on my list is Lauren Sant from the Caring Ambassadors Program. Ms. Sant, if you are here, you are welcome, and you have the floor, and you have 3 minutes.
Good morning, everyone. Chair Bailey and board members, thank you for the opportunity to talk to you today and for your hard work to address the cost structures that you're facing within our healthcare system. I'm really concerned that the question of process is not a dedicated meeting today. To add this fundamental question before reviewing 6 drugs in the same meeting really seems impossible given the past track record. But I am thrilled that you're discussing it and look forward to hearing the outcome of how you are going to define affordability. And while I appreciate that you receive some feedback from patients and providers, it's not enough to rely on for the critical decisions you're making. And I'm really concerned about some of the providers' feedback that appears to disassociate PBM formulary issues with limitations, and I don't understand it. So I don't know whether it's a survey function of whether they didn't understand the question, but it seems like if they didn't check off that PBMs or formula issues were a barrier, that was something that just kept being repeated throughout the entire document. And I feel like that's really misleading. And it's a false narrative because PBMs and insurance companies are who decide what can be accessed. And that's really clear from the feedback that you got back from the patients, that the insurance plans decide whether it's affordable or not. There was a lot of data that was insufficient that you gathered, that you pointed out was insufficient. But so I really encourage you to develop an effective process. Asking patients and manufacturers to provide personal or proprietary information on a non-secure means is not effective. And you really need these points to make your decisions. Also curious, did you do more outreach from patients that are taking migraine drugs or Vraylar or Entresto before this first meeting to let them know that their drugs were on the list? I personally lived with migraines for most of my adult or young adult life and teenage life. That was 2 to 3 days of lost school and work every time. If I had had the options that are available today, I would have paid anything. So please consider the nuances of each of these drugs carefully, as each one will benefit a different subset of people living with debilitating pain. As to Vraylar, it's my experience that the Oregon Health Plan does not choose an expensive drug unless it really works and is saving money in the system. The fact that so many Medicaid patients are on this drug speaks volumes. Living with schizophrenia is difficult enough. Do you want to create potential barriers and intervene in a patient-provider decision? Mental health drugs in Oregon have a carve-out for a reason. You have a lot of work to do, and you have some deadlines ahead of you, but deadlines can be broken, and the legislature will understand. So thank you for all your work.
Ms. Sant, thank you. Next individual on our list here is Anne Murray from Bristol Myers Squibb. So Anne, if you are here, welcome, and you have the floor.
I guess you're not the only one having computer problems this morning, Chair Bailey. Apologies. Chair Bailey and board members, I am Anne Murray, State Government Affairs Director with Bristol Myers Squibb, and my comments today have been the subject of our prior written submissions, the most recent on July 13th, which I'm sure the board members have before them today. But I do appreciate the opportunity to reiterate our request that Eliquis, apixaban, be removed from the prioritized subset list and not subject to affordability reviews. And in doing so, I wish to make 3 key points for your record. The first being that Eliquis has already been selected for and completed the process for the Medicare drug price negotiation program, with its maximum fair price set to begin on January 1st, 2026. Second, the board's own data sources, including the patient-reported data from the board survey, demonstrate that Eliquis is affordable for Oregonians. And third, Eliquis will very soon be facing generic competition. And I offer just a few brief background points for each one of those reasons. And first, at the board's I believe it was the June meeting, the most recent meeting, several board members did express a desire to remove drugs subject to the MFP process under IRA, as they've been addressed, obviously, in a separate process by CMS. And as noted, Eliquis was one of the first 10 drugs selected for that process, and a maximum fair price is set to take effect on January 1st of 2026. Given that the vast majority, 71% of Eliquis patients in Oregon who responded to your survey cited Medicare as their primary payer, focusing on Eliquis for review at the state level seems redundant, and it seems the board's very limited resources would best be directed to drugs with greater impacts to the Medicaid or commercially insured patients, which are more closely tied to your scope. CMS has communicated a timeline beginning in June 2025 to pharmacies and other drug dispensing entities to help them prepare for implementation of that program. Second, the board's data suggesting Eliquis is affordable. Currently, it's available widely to patients with over 90% open access among commercial plans and low out-of-pocket cost, and confirmed by the board's own data sources, including both the DC and the APAC databases, and patient-reported surveys, which clearly demonstrate that Eliquis is one of the most widely prescribed covered drugs in the state. The letter that we've submitted actually reiterates what the survey data said with regard to cost, but we believe that Eliquis should be removed from the prioritized subset, as its continued inclusion seems anchored in volume and payer costs rather than patient affordability issues. And finally, as noted,
I do believe that we're at minutes.
I'm
So
sorry.
I do believe we're at time. So thank you for your comments today. Next individual I have on my list is Primo Castro from Biotechnology Innovation Organization. Primo, if you're here, welcome, and you have the floor.
Thank you very much, Shelley. Dear Chair, before I start, I actually just wanted to, just confirm that you all received, the written letter that we had submitted. I didn't hear it this morning. Didn't see it in the actual materials that was, that was supposed to be some shown, to everybody. But Primo Castro, State Government Affairs Director for the Western Region. Dear board members, the Biotechnology Innovation Organization, commonly known as BIO, appreciates the opportunity to provide comments today. In the June 2025 meeting, board members made comments about wanting to standardize the review criteria and identify a need to establish a critical definition for key terms like affordability. What does that mean? These concerns stem from the board's aborted 2024 process, and it is prudent for the board to address before starting with reviews in 2025. As stated, a concern of jumping into affordability reviews for selected drugs without flushing out the broader process like definitions, review criteria, and more on how the board will measure affordability in this process. This also includes concerns of having so many affordability reviews in a single meeting, which does not allow to go deep into all the unique considerations of each drug. In addition, in June, a board member indicated to recommend to the legislature, that the orphan drug exemption be removed from Oregon PDAB's review affordability process. These comments were concerning for the entire patient community and represents a key misunderstanding of the critical role that the orphan drug exemption plays in ensuring patient access to life-saving treatments for individuals with rare diseases. BIO strongly opposes any recommendation to alter or remove the orphan drug exemption, which would, threaten the delicate ecosystem of innovation that makes these therapies possible. We respectfully urge that PDAB and state policymakers maintain, the rare disease exemption from affordability review, which provides a critical lifeline for rare disease patients to access these important treatments. With 95% of the 7,000 plus known rare diseases lacking an FDA-approved therapy, continued investment in rare diseases research and development is vital. Thank you.
Thank you for being here today. And for the record, I do want to reference the letter was received and is posted on the PDAB website, but it was received after the cutoff period for inclusion in the packets. So the letter will be a part of the August packet. So absolutely. Next individual on the list is Vanessa Latham from the Patient Inclusion Council, PIC, Ensuring Access Innovation, Ensuring Access through Collaborative Health Each Coalition. So Vanessa, if you're here, looks like you are, welcome, and you have the floor.
Good morning. My name is Vanessa Latham, and I'm speaking on behalf of the Each Coalition and Patient Inclusion Council, a novel coalition that brings together patient organizations, caregivers, and people living with acute, rare, and chronic conditions to advocate for patient-centered drug affordability policies. We appreciate the board's commitment to making medications more affordable, but we're concerned about the pace of the current review process. Reviewing 23 drugs and insulin products in just 4 months is a heavy lift for both the board and the community. Proceeding at this pace may lead to rushed decisions based on assumptions instead of facts. While we appreciate the measures the board has already taken to narrow down the process, we ask the board to continue narrowing down the list of drugs under review this year. A more focused process will help ensure decisions are thorough and based on solid evidence and avoid complications similar to those that occurred last year during the reviews. Additionally, we remain concerned about how these reviews could impact patients. Findings of inaffordability in Oregon could impact coverage decisions by insurers in the state and trickle out to impact coverage in other states as well. The unintended consequences of the board's decisions could leave patients facing limitations on coverage of their preferred medications due to increased utilization management, non-medical switching, and restricted formularies. To help avoid these outcomes, it's essential that the board includes strong input from patients and advocacy groups. Hearing directly from those that rely on these treatments will help the board understand real-life impacts of you all's decisions. We encourage the board to continue to do outreach to the public to supplement the input they receive from the survey and work directly with patient groups to understand and address patient needs. At the end of the day, affordability should be about whether people can get and stay on the medications they need, not just what insurers or states pay. We welcome the chance to work directly with the board. Our coalition includes a wide range of diverse patient voices and extensive experience with how people manage chronic health conditions over time. We're here to help keep patients' needs at the center of this process. Thank you.
Thank you. Next individual we have on our agenda is Daria McGrew from Pharma. Daria, if you're here, welcome, and you have the floor.
Good morning, Chair Bailey, members of the committee. Thank you. For the record, Daria McGrew on behalf of Pharma.
Appreciate the board's agendizing the discussion of what does affordability mean. Look forward to hearing that. Echo previous comments that disappointed it didn't happen earlier, and I think it will be difficult to really dive into that conversation and perform significant, review of your affordability reports at the same time. That being said, I do want to discuss, I'm going to speak generally about the reports, but I want to get into some kind of weeds about issues with the reports that I see. First of all, there appear to be math errors that cannot be explained in every report. There's a significant, in the review summary section, there's math when you're calculating the cost per enrollee and the cost per claim. There's math that just doesn't make sense. It should be a pretty simple calculation. I can't figure out how those numbers were arrived at. It appears to be, based on what I can see, an error in the Excel tables in their table 3, table 4, the green table in the reports. In 5 out of 6 reports, your cost per claim number appears to be in error, and it looks like it's 3 averages were totaled instead of averaged in those tables. So due to this, you are being shown a 3-fold overestimation of the cost per enrollee and cost per claim in 6 out of 6 reports. So that's an error that really needs to be addressed. The reports also, I appreciate that there is more detail on gross versus net pricing and the differences between the APAC and the carrier data. That's important that has been discussed in these reports. It does lead to the question why, when you look through the reports, if you just take a look at cost per claim kind of as a proxy, in 5 out of 6 reports, the net price cost per claim is more than the gross price of cost per claim. So if the net price is the price after rebates and concessions, why is it more than the gross price? That just can't be and doesn't make sense. And I think there needs to be some line of questioning on how the numbers are reflecting that. And again, we get into rebates and concessions. We have said for a couple of years now, we do not understand what a PBM concession is. That is a phrase or a number that was put into the data carrier, the data call. We have several letters to the effect of, we don't know what a PBM concession is. That does not track with the way that the supply chain works. So why are there 2 different numbers being separated when the manufacturers negotiate discounts with the PBM?
Ms. McGrew, thank you for being here today. We have exceeded the 3 minutes, so thank you for being here. Let's see here. So I now want to give some background related to the board conducting drug reviews per ORS 646A.694 and OAR 925-200-0020. At the June 18th meeting, the board voted on an update subset list of prescription drugs and insulin products. Today, we will begin with a review for 6 of those drugs: Vraylar, Entresto, Ajovy, Emgality, Nurtec, and Ubrelvy. I've been out of pharmacy for a couple years, so I apologize for the pronunciation of those drugs names. There will be a public comment period for each of the cost reviews. Speakers will have 3 minutes. Board members may have follow-up questions for the speakers. The board will hear from patients, caregivers, and individuals with scientific or medical background. So I do call on Courtney Whitlock, Senior Policy Analyst, to help us get started. So Courtney, welcome, and you have the floor.
Yes, good morning, Chair Bailey and board members. Appreciate your time this morning. I do want to provide a quick overcap of kind of what got us to where we are today. So I'm going to do a quick slideshow, if I can get it going. And hopefully everyone is able to see my screen. So you've seen this affordability review kind of timeline before, and just to kind of overcap where we're at. So in July, we're officially starting the reviews under our Senate Bill 844 and our rule and our structured rule -020. And along with the review of the material packets, wanted to kind of start off with, again, the rule and the statute provide the general structuralization of how to conduct cost reviews for impact to the healthcare system and patient out-of-pocket costs that may cause, an impact on the system. So as we start these reviews, I just wanted to level set where we are and how we got here. So again, July through October, we're going to do all the material packets to the best of the board's ability to review. If we start rolling over material packets into the next month, these are things that we will restructure and analyze what is the best way to get through all the reviews meaningfully. And then with the intention to identify the 9 drugs and at least one insulin product and within November, with a final report going to legislators by the end of December. So the board narrowed down last month from a larger subset list to a more structured subset list. And this was the review process that the board agreed upon. One, there was orphan drugs that had the designation. At the time, those were removed. There was 4 of them. The board decided to review just the insulin products for glargine, which we'll review in just a second. I have some questions for the board members regarding that. And then the board really looked at the data call, payer paid information from largest to smallest cost amounts, and then focused on the APAC numbers of enrollees, which include Medicare, Medicaid, and commercial. So hopefully having a broader selection of information to provide to the board for review analysis. And then to kind of narrow it down a little bit more, any drugs that had less than 1,000 APAC enrollees was removed. And then that led us to the 16 drugs that are selected today. We didn't get an opportunity to talk about the bucketing at the last meeting. The bucketing of the drugs were kind of preset by staff in case that did happen, just in the sense where we tried to identify drug classes of similar products together to make the review a little more meaningful. So the first bucket is primarily around the antipsychotic Vraylar, followed by the cardiovascular agent Entresto, and then the 4 migraine products, Ajovy, Emgality, Nurtec OTC, and Ubrelvy. My question for the board is, even though we're starting off with kind of bucket 1 or review number 1, does the board want to continue to also review number 2 next, or does the board want to jump into reviewing numbers 3 or 4, which are more aligned with the insulin products? So this is the first one. Apologies, try that keeps bumping up. So this is 3 and 4. So before I go on, I do want to kind of get an assessment from the board so we can start setting up the next review packets that will be meaningful. So I'm going to just stop there and listen to any feedback from board members.
Courtney, for the record, I want to clarify a couple of things. I cannot raise my hand on this platform, this tech platform that I'm using. So if I interrupt more than usual, I apologize to my colleagues. I'm unable to raise my hand. Also, Courtney, I'm finding it a little bit difficult to hear you. I think your audio is working properly, but if there's any way to turn it up, that might be helpful. And I will do so on my end as well.
Yeah, I know my audio is all the way up for my
Okay.
mic.
Okay.
Thank you for letting me know.
It may just be on my end, but I did want to reference that. So it wasn't specifically relevant to your question, but I did want to put that up there.
All right, thanks. Dr. Hartung, I see your hand up.
Yeah, so the question is, does the board have a preference on what cohort of drugs we review in what order?
Yeah, exactly. So we are starting with group number 1. Is it the preference to continue with group number 2 for the next drug grouping, or start with 3, or start working on 4 as well?
I mean, I have concerns about the review packets. some of them were echoed by some of the public comment and just kind of some of the coherence elements of the review packet. And so in terms of the order of the reviews, I think we should do the glargines last because that's going to be complicated and somewhat different than the other ones. But I believe we should take a close look at these at least the review packet structure. And it seems as though, we're kind of pulling together all the world's data on these drugs and plopping it in these review packets, when I think there could be some choices made in what types of data are being analyzed and surfaced in these things to help us a little bit more, because it's a ton of work for staff to put these together, I'm sure. And I'm not sure all the information as presented is as useful as it could be. So I guess that's not directly answering your question. I don't think the order makes much difference, but I just want to, I'm super concerned about process and the volume of drugs here. So I just wanted to bring that up to the board.
Yeah, and we're going to touch base on that in just a few minutes, Dan. I just, for staff to know what our next step is so that we can start working on it today, what the next, and I understand that the packets need work. And, this is one of the reasons why we're here today, is so that staff can receive additional feedback from staff or from the board members to how to shore up these. And the nice thing, remember, is that we're just reviewing the material packets. We're not voting, and the board is not making any decisions. So anything that you apply for feedback to staff today will be implemented into the future packets, and hopefully shoring up a lot of that information. So, but I want to get to to Chris Lehman, and then I'll.
Yeah, Courtney, to Dan's point, I'm fine with the order as it is. I mean, as long as we're discussing the process after this, like to me, it doesn't make any difference, the order. And I agree that glargine should be last.
All right. If that is the overall census, then I will just get the next grouping going, unless the board member tells me otherwise. Thank you. All right, so that's the end of the slides that I have to kind of go over. I apologize, it was short and sweet, kind of hopefully provide just the structure, what got us here today. Now, regarding the material packets themselves, again, a lot of information was provided to the staff to have to set up in a small amount of time, and we understand that has led to some confusions, and I do apologize that I wasn't able to attend all of the touch bases with staff or the board members over the last couple of days. But Dan, I think I'm going to lean into you a little bit on this, since you kind of seem to be the one vocalizing, and Chris, probably as well, you as well. With review of the packets, what are your primary concerns that we can kind of address right now? And then I can hopefully clarify, or have Pay also clarify, and then we can kind of see how to determine other options.
Do you want me to summarize my concerns?
Yes, please.
Okay. Well, it's helpful. I think it's helpful to look at an actual packet and think about, think this through about what's in these packets, and like what's helpful in terms of like our goal here is to understand affordability from the health system and from the patient. And so how do we organize this data to help us make those decisions? And we haven't even talked about what is affordability. So that's like a second point, but just the data structure of the reports was concerning to me, just because it seems as though we're just at this deluge of data from APAC, from the carriers, from the clinical summary, from, we have WAC, we have the NADAC stuff, the acquisition costs from pharmacy, and it's just kind of, it's all there, and it's just hard to put everything together. And like I was making like little cross tables to try to synthesize stuff across these big reports, because it was difficult to pull different pieces from places. But so I don't know if we can kind of just start with one of these and gonna, I started with Vraylar just because it was top of the list of PDFs. And so maybe we could just start working through one of these and kind of thinking through, what type of information. And actually, I've also been looking at other state PDABs and the reports they've generated, to see, because that's kind of one of the things that we're a little, we're not as mature as some of these other state boards. And, we've talked about, we can learn from other boards and their reports. And I think that, sometimes they've done a nice job of summarizing some of their data, and they're using different data sets, but I think it just gives us some insight in kind of what's most useful in terms of like the data we have. The carrier data, in my mind, because it's just this limited subset of information from whatever 11 to 12 different commercial carriers in the state. The real value there is it gives us net costs and discounts and concessions, even with the caveats echoed by in the public comment about how those concessions are actually quantified. But at least we get some insight into just net costs and concessions and rebates and things like that. But the global picture of like utilization and costs, and even out-of-pocket costs, I was trying to understand, our out-of-pocket costs from the APAC data, it seems like APAC data has got the view on total utilization and expenditures in the state. And so maybe we should just be leaning on that throughout the whole report, with some exceptions and some other data sprinkled in.
So just as a reminder, APAC is it is gross, but it's also across all reporting carriers that are outside of what the DPT or the drug price transparency reporting requirement is for the board to look at. So the data call information is specific to some of that information, but we can lean into APAC for the drugs that we've identified under the DPT reporting. But it is a very overarching and includes Medicaid, Medicare, and commercial insurance, but not as fine and detailed as the data call information. So I totally hear what you're saying, and we can go with whatever the board prefers. I just want to make sure that we're staying in alignment with our requirements.
I mean, personally, I was looking at APAC for like kind of the Oregon global lens, and then looking at DPT, trying to get a better perspective of net.
Understood.
Right. Yeah. I mean, I kind of looked at the carrier to just get a sense of basically what the rebates were being sourced by the commercial payers. Our mandate is across the entire state. So, obviously we don't have authority to do any promulgate any rules or laws or things like that. But I believe our mandate is across payers. So I think APAC, it also gives us information out-of-pocket costs across those different payer groups too, which I think the carrier data, the data call data doesn't provide. So except for commercial.
Yeah, except for just commercial. Yes, you're correct. So thank you, Dan, for that feedback. I want to give any other board members and opportunities to kind of jump in and provide some feedback about the structure of the material packets before I dive into some other questions for you.
Dan, are there other things? This is Chris. Sorry, I didn't raise my hand. I just talked. I apologize. Are there other areas that because I felt overwhelmed by it too a little bit as I was going through. Are there other areas that you think could be removed from the packet?
Yeah.
With a report for each drug? Because I just, it was a lot.
Yeah.
That I don't know that was really relevant to the affordability, I guess.
So every part of this section is in our statutory requirement, which is why we indicated here under each of our ORS why they have to be in the report, because this is part of our statutory requirement, and then where it lands within our rule, and then the data sets that were used. So unfortunately, everything that's in here does need to be considered as an impact to the system and patient out-of-pocket cost. So within these sections, if there's something that is not meaningful enough for the board, staff can look at minimizing the information a little bit, but we tried to provide what we had access to in a very small amount of time. And again, we understand that this whole process of setting up came from a very, very, very large data set that we had to spend quite a bit of time really looking at and analyzing and structuring to get it into this material packet in a small amount of time. So just for these 6 drugs.
I
But
apologize for interrupting.
if there's something more specific, unfortunately, there's no sections in themselves that we would be able to take out because they're all part of the statutory requirements.
I apologize for interrupting. I'm not able to raise my hand at the moment. My concern is that the information, though required, is extensive. My suggestion would be for the board to discuss, much like we did for the selection of drugs. We honed in on a couple of different important points for the selection of the drugs, whether it was the cost of the drug or the number of patients, whatever we used during that process. For me, I need to know what measurements, what metrics we're going to use to decide affordability. And then our reports and our packets going forward, once we've identified those, need to have some section that pay particular focus to that for me. The other information is useful, required, I understand, but we need to start getting down to what is affordability, what is affecting. For me, it's patients, it's out-of-pocket costs, and some of the comments in the public comment, for example, incredibly interesting to me that I hadn't realized that those things were happening, like on the MFP, if I use the right acronym, drugs with the federal program, the out-of-pocket costs are actually going up. Good grief. Well, anyway, my suggestion is that we hone down what we think causes affordability issues for Oregonians, make that a focus in our packet, at least in part of it. Thank you.
Yeah, Chair Bailey.
Finally figured out how to raise my hand. So a couple of thoughts I do have. I did want to lean into, I think, some nomenclature that we used in previous meetings about costs, and that this kind of from the lens that I think this packet is significantly enhanced from what we saw last year. So I definitely want to thank staff for the time that you put in. Even like the 340B section was new, and those things I really found value in. And I also found value in sharing the information, but also your reference as to what can be used to make decisions and what could not be used. So that's just one thing I wanted to share. But I did want to lean into kind of this concept of cost, that from my perspective, what these packets are doing is showing what the costs are, not necessarily what is or is not affordable, but we're shining light on what kind of the costs are on all the different pieces, or as much of the pieces of the ecosystem that we have access to. So I'm not disagreeing with my colleagues in any way, but wanted to share this I've been looking at this from the lens of cost. But the other thing I did want to ask, Courtney, is maybe you could help remind all of us, based on our previous meeting, I believe we had 3 metrics that we looked at to help identify that second round of the subset list. So as I'm hearing board members reference kind of what are we looking at as our foundation that we're at least looking at this lens through, I think we had 3 things that we really helped drive us for the list that we have before us today. Would you be able to help remind us of what those were? Because that is what we used, and we should use that, I believe, as our view, or at least our initial view of how we're looking at things, which is how we developed the subset list.
Yeah, which it does still create a challenge because how
'Cause
it was
it's-
reviewed by the board was looking at the data call information filtered by the largest to smallest cost,
Mhm.
the data call, and then through APAC, it was the number of enrollees by the claim line of business. So the Medicare, Medicaid, and commercial lines, how many were enrolled at the time. And then any drugs that were less than 1,000 APAC enrollees. So I don't know.
I know that doesn't solve our problems, but I did just, not our problems, but it doesn't maybe provide answers to all of our questions. But thank you for reminding us that that was what we, and the third again, Courtney, was the,
Yeah, drugs less than 1,000 APAC enrollees was removed.
Thank
So
you.
anybody less than or more than 1,000 stayed, less than 1,000 was removed. And that was only on the APAC side.
Would one kind of efficient way to have this discussion be for maybe Courtney to guide us through the Vraylar, and then possibly Dr. Hartung, you might be able to provide some feedback after hearing Courtney go through Vraylar, other the pieces or ways, I guess, additional information or less information that you saw that would be helpful. Would that be an efficient way for her to share how it's presented? And then Dr. Hartung, for you to share your insights and thoughts on how you might structure it?
Yeah, that's fine. I don't want to dominate this conversation at all, and I want the board to. But
No,
I think having
important
Courtney,
discussions to have.
yeah, and like for each section, maybe we can think about like if all this stuff absolutely needs to be in this report, maybe we can front load the report with the critical stuff and put all the rest in an appendix or something like that. Because I wasn't aware that this is all mandated to be in a report. So anyways, but yeah, again, I don't want to, I just want to contribute and but allow other board members to offer their insight as well.
Yeah, I appreciate that, Dan. So if you talk about front loading, super high level under the review summary, tried to capture for each section what it was, like the most significant numbers in that section. Happy to work on improving this. Again, it was, you know, trying to get it to be posted the week before. So time restraints were kind of a challenge for us to make sure that everything accurately was indicated from section to section. But I don't know, you know, how meaningful this section is, or if you wanted something more elaborate for a section.
Yeah, so the executive summary at the top, I think it's fine. So one kind of where you were, one overarching question I had is we kind of have it broken down into like cost to healthcare system, cost to payers, cost to patients. And then my understanding is, you know, the cost to the healthcare system, I guess, you know, the cost to payers is basically just subtracting off the cost to the enrollees, and it's pretty, the differences between the two are pretty small because the out-of-pocket cost for patients is a small proportion of the total healthcare cost. So I almost wonder if we just like focus on the cost of the healthcare system and then cost to patients, those two pieces, because in looking at the cost of the healthcare system versus the cost of the payers, they're pretty close. And you can kind of see that if you just look at these high level numbers here, 38.6 million versus 37.0 million. So that's one way I think to streamline things if people like that.
Yeah, as long as it understood that in our statutory language, the meaning of healthcare system is primarily focused around carrier payment for this review until we can get additional information from any sources. And then any out-of-pocket cost information would be identified separately. So I'm happy to do that. It makes it a lot easier data-wise, so we're not having to show the totals between the two. and they're already separated out for the discussion to meet our statutory requirement. Do any other members, Lori, Dan Kennedy, Amy, any other feedback on kind of this perspective of only identifying the healthcare or the payer cost and the patient out-of-pocket cost? Yes, Lori, I see your hand up.
So I agree with everything that's been said in terms of a landscape that feels like a jungle that we're supposed to find a pathway through with a few limited tools. It's difficult, and partly because we have a complicated healthcare system with multiple variables and how to figure out which ones are more important than others. I would agree. I think we have to be careful if we do too much of a drill down on the various small group versus large group versus individual. It gets to be mind-boggling, and there's so little that we have really to control in that arena. Anyway, so I basically wanted to just say I'm in support of what we're doing right now.
Thanks, Lori. Chair Bailey, I see your hand up.
Thank you. I mean, one thing I would share though, I mean, since, you know, very clearly for the record, this board does not have any UPL authority. I actually very much find a lot of, if we look at part of our role is kind of shining light on the pieces that drive what could be high costs related to drugs. I very much that information related to what large groups pay versus small groups and things, to me, is exceptionally valuable in providing that information not only to board members but to the general public, because it shows the massive disparity in out-of-pocket expense and the payer expense. Like, to me, it was actually some of the other pie charts I was talking about, but from my perspective, that is very meaningful information. Now, is it will it necessarily lead to whether or not, you know, the board determines a drug that may present affordability challenges? I don't know, but I think showing this type of information not only to the board but to Oregonians and to the general public is very meaningful, in my opinion.
And just from a data perspective, it is kind of easier since we already have this broken out within the lines of business and the market type to show kind of cost impact if we can keep it.
Personally, I would not exclude it because I think this is an important part of kind of the statewide and national discussions. This is showing some of that.
Yeah. So I appreciate the conversation, and this gives us great kind of guidance. In the perspective of the review of the drug, so the board needs to be having meaningful discussion about the impact of these costs to the healthcare system and patient out-of-pocket cost. Is there something within these packets that board or the staff can help kind of set up to facilitate those conversations more easily? So when we have a large number of drugs to review, the board can kind of say, this is a good number to work with. This is not as meaningful, short of what I'm showing you here, where it's just already broke out per class. And do you want it claims? Do you want it enrollees? Do you want total spend? Is this all meaningful, or is it something else that we need to lean into? And if it looks good, then we can move on and have some other conversations. Yeah, Chair Bailey.
Thank you. I'm not suggesting it looks bad, but I mean, from my perspective, you know, when we look at the letters from manufacturers and things, it appears as though many manufacturers do have patient copay cards and access to alternative channels for patients. So from my perspective, I very much like seeing the impact to the healthcare system or to the payer, because from my perspective, that in large part impacts premiums and access for Oregonians. So I very much obviously value patient feedback and the patient lived experience and the patient copays, but also want to not lose sight of the fact that what drives an expense to a payer ultimately has an impact on the patient.
Yeah, and one of the challenges that staff does have is any insight to manufacture patient assistant programs or any other programs that offer patient relief. So basically what you see is the numbers in some capacity that have impacted the enrollees themselves.
Well, but in one good thing, the manufacturers also share that in the feedback that they provide to us, right?
For the most part.
You know, not always, but to your point, we do receive that information often from the manufacturers themselves. I know that it doesn't become part of the packet in your data analysis piece, but is certainly part of the packet when board members are reviewing information.
I do like the inclusion of both APAC and data call. For me, I want to see where the leakage of money out of our system is that goes, and how that affects the affordability of a drug for a patient and for the plan that's trying to pay for it, who pays the majority of the bill. You know, to have, for example, our example of Vraylar, where 25% of the rebates, well, it's reduced by 25%, but only what, 1 or 2%, and please correct me if I'm incorrect on this, but most of it is retained by the PBM. Where is the money leaving the system that does not help patient care? That's my concern. That's what's going to drive my decisions towards affordability. I want to see where those disparities happen and where it's making it more difficult for the plan, for the payers, and for the patient to afford the medication.
Okay. And again, we try to capture that, John, within this section as best as possible, because again, we're limited to what we got back from the carriers, and this information tries to capture that as best as possible. So we can work with that section. I did want to touch base about the therapeutic alternatives. And again, I know that in Vraylar, there was only one clinical review of a drug, and I apologize for that. That was just an unfortunate oversight. So the drug under the clinical review was the Vraylar to the Capillata, but it did have others, but we were able to pull the APAC information for each of the therapeutic alternatives. You see the cost impact, but again, it's all gross, right? So we don't know what the discounts. It is our hope that for the next review, we're able to get the therapeutic alternatives in a timely enough manner to include in the data set, or the data call, so that we'd have more accuracy between what it is between APAC and the NET. But due to the quickness of having to turn around for this review, we weren't able to capture all of the therapeutic alternatives in enough time to send in the data call. So we're only working with APAC information, but hopefully it kind of gives you a perspective of what that is. Yes, Dr. Hartung.
Yeah, I appreciate, like we're on this table here, there's just so much information in this table. And it's good, but it's just, it takes quite a bit of cognitive energy to like figure out, okay, what's the average cost per patient per year, even if it is gross to the system, from the table that's like, what is this, is like 8 by 10 essentially, and trying to figure that out, paid average per claim. Sometimes that's misleading because some drugs are, I don't know if these are injectable, like these are long acting. I assume they're all oral 30-day supply. So I have questions about like the apples to apples comparison across these drugs. And so part of me wants, just like, we have this section on WAC in the first part. You don't need to scroll there, but there's a section on WAC where you have inflation of WAC, which is fine. But like, just like a simple table that has the list price of the drug under the review and all the therapeutic alternatives with like the 30-day equivalent list price of all the kind of alternatives would just be very helpful. In terms of just sussing out, how do they compare just in terms of their list price. And again, we have some sort of semblance about the discount from the carrier data, so we can kind of put that in our head from at least one drug, for at least the drug in question. But just something like that, just like a simple table that has the average 30-day or annual price for drug X plus its therapeutic alternatives or comparators would be helpful.
Yeah. That's great feedback. Thanks.
My thought.
Yes, Chair Bailey.
I fully support what Dr. Hartung is referencing. I do just want to reference for the record, one of the challenges I suspect we have with that is we have to batch for confidentiality related to pricing and things. We have to batch all the NDCs like for certain ones like together. So to your point, looking at Vraylar, we don't know if this is Risperdal Consta or Risperdal Oral or, you know, like I fully hear what you're saying. I can suspect that the staff may need quite a bit of additional clinical support to be able to crosswalk that. Is that accurate or no?
Yeah, so I'd have to go back, but we pulled everything based off an NDC level. And again, everything's aggregated.
Yeah.
All carriers. So it's not like anything can be significantly identified in this data set. So I'm pretty sure it's doable to show what we can.
30-day supply of one.
We're trying to get it a little more accurate with the naming conventions of the naming, the drug dosage going forward.
Well, and to Dr. Hartung's point, like some of these could be an injectable dose twice a month.
Yeah.
Right. So I fully hear what Dr. Hartung is saying related to that. That per unit is sometimes hard because some maybe 1 unit a day, some could be multiple units a day, right?
All right.
I just operationally trying to figure out the how of supporting staff in doing that.
Yeah, no, it's definitely like some additional work, but I feel like by stripping out some of this extraneous stuff and focusing on the more, you know, I would say more relevant information, even though it adds work, would create a better product that's more useful to us.
Does it seem to be pretty meaningful then to have more information around the therapeutic alternatives to the drugs as much as possible?
We focus on branded only. So like the Risperdal or the paliperidone, those types of things have such significant delta in the cost savings. Like would it make sense when we're looking at therapeutic alternatives that where there is one that we look at one brand versus another brand instead of adding all the generics too? Would that be a way to reduce some staff time, or is it not necessarily saving much by reducing things in Excel?
I think having generic data on price is important as a comparator is important because it highlights you know why, you know, even though they're not perfectly equivalent, it highlights the important differences in cost that may be contributing to the affordability issue.
I guess I was just trying to think of like side effect profiles of like a drug that essentially came to market around a similar time as the other drugs in the therapeutic class. But I hear what you're saying related to that clearly it is important to show alternatives.
I mean, I think this comes up with the migraine stuff because we have like none of the migraine reports that include like the triptans, which have been forever been the, you know, gold standard for, you know, aborting a migraine. And obviously there's differences, clinical differences, but they're still used and they're still considered effective therapies. So, and why they're not in there is, I'm not sure. Maybe they are. Maybe I'm mixing up reports.
Yeah.
And if they're not, it's because of we got the assistance from a clinician and they tried to create the closest therapeutic equivalent or alternative to the drugs. But again, happy to work with our clinician to get some more information on that kind of stuff down. Well, I appreciate the conversation. I I feel like just to improve the packets, staff has some pretty good guidance. I know that there's been this conversation about determining affordability for this kind of review structure. I just want to remind the board that you don't have a definition because the outline of affordability is already in kind of the statutory requirements to look at things. So, which I know kind of makes it challenging when you don't have a specific way to define affordability, but it also provides you the flexibility to ensure that you're looking at drugs and drug not equally across. So if you have a specific drug that needs to be reviewed one way versus a drug that needs to be reviewed another way, you have that flexibility, but you do have the rules to fall back on. So if you recall that in Rule -020, there was a different additional components to the review for board members to look at. So, but I think the thing, as Chair Bailey was saying earlier, kind of pulling out what the cost impact is. And since you've already based majority of your initial selection off of highest to lowest drug cost, I know that doesn't help when it comes down to the individual drugs themselves, but is there a way that the board can start having a conversation about how to look at this drug? And we don't have to start with Vraylar. I don't know if it may be easier to start kind of reviewing at the therapeutic class level with the migraines, to see with how they are in comparison of each other. But I would like to have a little bit of guidance on how the board would like to start these discussions around cost and the cost to the system or patient out-of-pocket cost. And I know it's a little challenging when the material packets are in depth with a whole bunch of numbers and information, but any insight from all board members, preferably, on ways to look at the information provided. And I can also pull over the dashboard, and we can look at numbers and concepts from there too.
Courtney, I do think if you can pull up the dashboard, it would be helpful. I mean, I do know that I've heard it throughout this meeting. You know, there are multiple board members that have been very passionate about having this affordability discussion. So I would very much welcome those board members that have felt strongly about us having that discussion, that we jump in as we're looking at these things. I already, I guess, set the stage related to my personal feelings related to I don't primarily weight, but I primarily focus on the cost to the system because I believe that drives everything else. But obviously I am just one voice. And again, there's been other passionate voices that have referenced it. So I would like us to be having this discussion. And so Courtney, thank you for pulling up the dashboard.
Dr. Hartung.
I was just going to say, I think you mentioned just having some discussion about affordability from the health system and the patient standpoint. From the APAC data has out-of-pocket costs for patients, and to my understanding, that should be, obviously we don't know any information about, we have no systematic information about patient assistance programs and things like that. So we know that's in the background, but it does have out-of-pocket costs across all the different payer groups. We know Medicaid, there's, nominal out-of-pocket costs. So Medicare and commercial. So we could really, focus in on just a nice high level summary of out-of-pocket costs for the drug in question with comparison to the other drugs in the categories, I think. And I think doing and not presenting like every slice of information, but maybe like average out-of-pocket for the enrollee, and if they're can be a way to like standardize it. So we're doing apples to apples comparison on, per 30-day supply or per, because sometimes like patients aren't, if the average is skewed in one way because patients are only taking it for a few months for the year. And so just being more careful about how we're using the data to quantify, maybe the average out-of-pocket costs, but across the different payer groups.
And just a clarification, Dan, not all drugs have multiple drugs for the therapeutic classes. So some of them will be individually reviewed without comparison unless it's just to therapeutic alternatives. But if we want to start with the migraine headaches, we can show the comparisons across multiple drugs for something like that.
And in our previous meeting, I know this is like the Excel version. Didn't we have I'm trying to find it right now on the dashboard, another part that Heather was kind of helping us navigate through the other time where we were able to easily pull up. Yeah, I think it was that. I don't know what's easier for colleagues. I know many of my colleagues are much more brilliant in Excel than I am, but I have found the dashboard useful.
Yeah, Dr. Burns, I see your hand up. Apologies. Amy.
Yeah, I was just gonna agree with Dan. I think leaning on the APAC data is smart. I like the data call data just as kind of colors the picture a little bit, gives you, as Shelley was saying, more information around some of the broader picture that APAC's not going to cover. But as far as like consistently comparing apples to apples and oranges to oranges, like the all payer, all claims to me seems the most reasonable to use to define how we want to look at different data points over and over again.
And Chair Bailey, I see your hand still up. I'm not sure if
No.
that's from, okay, Chris, I see your hand up. Maybe. Chris, did you have a comment that you wanted to add in?
Yeah, sorry, I didn't unmute myself. Courtney, thanks. I totally agree with what Dr. Burns and Dr. Hartung said. And in terms of apples to apples, for me, it wasn't comparing the therapeutic alternatives. It would be nice to have like a summary section at the very top of the reviews that I think had, using APAC data, number of patients on this prescription, number of claims, like prescriptions dispensed, total cost to the system for APAC, total cost to the patients, and then like a change in WAC over the last 3 to 5 years that just puts in a good summary up at the top that, for every drug, we're focused on not necessarily focused, all this data is necessary, and we're going to use it to color or affect our opinions. But it would be nice to have that standard set of data right at the top called out for each one of them. And I don't know how Dr. Burns and Dr. Hartung and others feel about that, but I think that would help sort of set the stage nicely for the rest of the review.
That's great. Thank you, Chris. I appreciate that feedback. Dr. Hartung?
The other thing, I was reviewing some other state PDAB reports, and the other thing that I thought was really insightful that some states were doing were looking at utilization over time. And I know I hesitate to add like a second or third dimension to this, but like, seeing the trajectory of patient utilization is pretty striking in certain cases in helping us understand what the future is going to be, because we're just have 2023 cross section. But if we know this drug is just growing use, it may kind of tint what we think about it in terms of making recommendations. And so I know the APAC data is historical, and so I want to like I'm totally sympathetic to all the work that's been put into these packets already. But if there's ways we can strip out some of the extraneous stuff and just like focus on really the key information and maybe adding in a couple things, I think would be really helpful. And I'm happy to like meet with staff to discuss my ideas in more depth too.
I appreciate that because I think we need a lot more
Yeah.
guidance from perspective, Dr. Hartung. Chair Bailey, I see your hand up.
Thank you. So when I was like doing the drill down of all 26 drugs starting last month, the part of the dashboard that personally I was leaning into a lot and looking at things is the APAC alternatives, equivalence, and biosim subset comparison. To me, at least in the lens I have been looking at things at, so it's not this one, I guess it's the subset comparison one. I felt that at least for the way I like to look at information, I felt like this was really helpful because I was able to look at the total spend, the total payer pay, the number of enrollees for the baseline drug, the drug on the subset list, and the alternative. So I just want to say I felt that this part of the dashboard was very meaningful and seemed to present it. Now, it doesn't address DPT, but when we're looking at APAC as a global, this to me gave a great snapshot.
Okay.
Not that the packet, clearly the information in the packet is valuable and meaningful, but this was a piece of the dashboard that I was leaning heavily into.
Thank you, Chair Bailey. I just wanted to show something then if we go into.
And I don't know, there could be very, very much other parts of the dashboard my colleagues prefer, but because so far I've heard a lot of discussion on APAC, that's why I wanted to lean into this.
Yeah, and again, looking at it from kind of a therapeutic class, having multiple drugs in the class is helpful in the comparison for cost impact, patient out of pocket, and
I know not all drugs have it too.
Yeah.
So,
but as an example,
but I found most did. I think when I looked at all 26, I mean, clearly, and that's why the openness and flexibility related to affordability we do meet, because some drugs wouldn't have the same way of viewing it as other drugs within a class.
Okay.
In my opinion.
So just to be mindful of time, because we only have about an hour and a half left of.
And we do believe, I didn't announce Courtney, but I do believe we're going to take about a 5-minute break at 10:30 as well.
Yeah. So I just wanted to see if we wanted to take a break and then come back and try to do probably the therapeutic class of the migraines, just to see what we can, what the board can conceptualize for possible discussions regarding the drug, just to kind of level set as an example. And then also be mindful if there was any time for, I don't know if we have anybody signed up for
Courtney, we do, we have some letters that I need to make sure to reinforce, but we do have individuals signed up to speak for Vraylar, for Nurtec as well, and then I also need to reference those who submitted letters.
Okay. Well then, Chair Bailey, I will leave it in your guidance.
So I'm going to go ahead and call the 5-minute break right now. So we'll convene at 10:32 a.m. Pacific. So we are now on a 5-minute break. I am welcome, and my apologies for the delay. Before we proceed, Melissa, can you please call roll to confirm we have quorum so we can advance these discussions?
Yes, we'll do that. Yeah. Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy. We'll come back to Dan. Chris Lehman.
Present.
John Murray.
Present.
And Dan Kennedy. I don't see Dan in the meeting.
Okay, Melissa, do we have quorum without Board Member Kennedy?
Yes, we have a quorum.
As long as we have quorum, we'll go ahead and advance. Thank you, Melissa. So Courtney, you have the floor.
Sorry, technical difficulty, couldn't get off mute. I'm going to share my screen again, and I pulled up just the drugs under review through the dashboard and set it up on the filter for total DC spend, which is the original criteria, one of the original items to drill down to the list of drugs selected for review. The other item, again, was the impact or the APAC, the total enrollees. But between these few columns, you can at least get a understanding of the cost between the data call and impact for spend, claims, number of enrollees. I just wanted to start off with that as we kind of guide into this discussion. I'm not sure how much we want to lean into anything in the material packet for these discussions, or just utilize the material packet as a reference point for anything that has to do with either the WAC price or maybe any of the discounts, the price concessions and stuff like that. But I think just to kind of get the conversation rolling on these drugs, is there a particular drug or that the board would kind of like to start a discussion for kind of review process?
Courtney, based on the number of letters and individuals signed up to speak, and based on our previous discussion of my colleagues, I think that we should go ahead and focus on the migraine products, not to suggest for the record that they do create or do not create any more of a cost or affordability challenge than any other drug, but this is just for the board to work through the beginning of this process. So unless any of my colleagues disagree, why don't we go ahead and start with migraine?
Okay. For that, I'm going to go ahead and take out Entresto and Vraylar for initial discussion. So we're looking at total APAC spend. We're looking at 14.7 mil, with the data call at 5.5, 5.6. Again, I'm not sure if this is the slide to start the conversation off of, or if there are other sections that are more meaningful, such as the APAC. I apologize for my flipping through this really quick. Yeah, so it's already here on the migraine headache. To look at maybe the overall APAC through the therapeutic alternatives and equivalents. So board members, when you're thinking about measurements that you want to work with for cost impact, is there anything that stands out significantly to you that would?
I mean, from my perspective, the total spend per claim would be kind of, not to suggest that these are month supplies, because I know that migraine specifically is one that may not always be apples to apples on, on the frequency or like the dosing of this stuff. But to me, total spend per claim, total payer paid per claim, those types of numbers seem to be ones total enrollee paid. Those seem to be numbers that I would think as a board we would want to discuss together.
Yeah, I recognize Lori, your hand.
Oh, my apologies. I can't see the hands raised. My apologies, Ms. Hoagland.
That's okay. A couple things from a clinical perspective is I'm really happy with that we have the migraine products, which are all pretty new, and I was struck by how few people from minority groups are treated for migraine. And so my thoughts going into this is we really would be good to have a migraine product that was available to a broader group of patients. And then some of the thoughts of the Nurtec being preventative and also for acute pain. So it has a little broader possible use, as well as oral medicines being perhaps a little more available for a broader population of people than injectables. So those are just things that come into my mind besides pricing. Yeah.
Thank you, Larry. I'm pulling up if I can. I'm going to share some information in the packet. I'll get to in just a second, Dan. So following your information, Lori, this is one way that we broke out kind of the impact from a clinical perspective of the therapeutic alternatives. So again, we identified Nurtec OTC, Ubrelvy, and then a couple other therapeutics as rapid acting or small molecules. And then how they treated acute, episodic, chronic, and clustered headaches. I don't know if that's a significant impact for decision making, but that was broke out on how each drug kind of impacts the system, prescribing differently, and then how it can impact either the number of utilization or the cost overall. And I apologize for kind of flipping between multiple sheets. I just want to make sure that the board is aware that we did have this information available. Let me see if it runs down. Yeah. I thought I had something else in here. No. All right. So again, from what you were just saying, Lori, that this kind of helps identify some of those prescribing, how the drugs are prescribed or for treatment.
Yeah, and the idea that the Nurtec, of course, has a little broader use as well as an oral is a plus, as I see it, for being an important medicine. And also the idea that this is available to the commercial market, but not as much to the Medicaid, Medicare populations, and how a UPL might affect that.
All right. So is there anything else that the board wanted to lean into kind of?
Could any of the clinicians here maybe clarify which of these drugs? I see that some are for prevention, some are for episodic. Would anyone here be able to clarify, for example, which ones are injectable versus oral, or which ones would be taken like QD dosing, or which ones are taking episodic? Just because when we're looking at dollars, is that I would think we would want to be mindful of that.
I just had some notes. Yeah, because there's clearly some differentiation, as was noted, that Nurtec is for treatment and prophylaxis. Ubrelvy is for treatment, and Ajovy and Emgality, I'm sorry, I don't.
Emgality.
Yeah, are both for prophylaxis, just alone and not for treatment. And then I think the ones that are MABs at the end are all injectables.
Yeah, and Vipeti is an infusion.
Yeah, so there's a lot of dimensions here. And then we haven't even touched on the triptans, which are, again, like I said, just have been used from time for abortive treatment. So
Aimovig, Ajovy, Emgality, they're all injectables that are used once a month. Pedi is an infusion. And I don't know how often that's dosed, but I don't think it's once a month. It might be once, every quarter or something like that. I'd have to look it up. Nurtec is treatment, so it's for acute migraines as needed, and then every other day for prevention. It's an oral medication. Ubrelvy is only for treatment of an acute migraine. It's oral. Qulipta is preventative, and that's oral and every day. I don't know about the last one. Zaspret. I'd have to look it up.
At something, cost comparisons and treatment, we can work to see how we can break it out a little bit better. Dan, like
So
you
Nurtec's
suggested.
going to look a little weird because it can be either, and the amount that somebody might be prescribed per month would be dependent upon whether or not they're using it for acute migraine treatment or preventative migraine treatment.
Okay.
So that's going to affect how we compare it to other things. And that would be hard to tease out.
Yeah, it would.
That's a great point, Amy. And then just, I think, you could get at that a little bit if you just had like, again, WAC estimates of, what's the monthly cost for maybe treatment versus prophylaxis based on WAC. And then, just with that in mind that obviously WAC is not what's often paid, but at least it's a benchmark. I'd be curious about, since I'm talking and my hands up, I'd be curious about, I look at these numbers like total payer paid, 13 million, 10 million, 9 million, 6 million, in APAC. And I mean, it seems like a lot, but it's kind of divorced of any context about like what's the entire, expenditures for within this neurology drugs or migraine drugs, or so it's hard to like understand. I'm trying to understand if it's truly a impactful category for payers. I mean, obviously 13 million is a lot of money, but Entresto was used by 10,000 Oregonians, and I'm sure has multiple, it's probably close to quite it's many full times higher spend. So I don't know if there's ways we can contextualize that information better.
We may have to meet offline so I can show you some of the data points, Dan.
I don't know if other board members have difficulty with that as well, or.
Well, I certainly hear what you and Dr. Burns have said, loud and clear, that in a way, I mean, these are very different, right? Some are different in how they're dosed, how they're used. So, I mean, I hear very clearly these are not apples to apples.
Is there any other way to kind of permit, whether it's clinical, pharmaceutical, patient centered, to look at the cost impact? I saw.
Yeah, I don't know, Courtney, thanks for recognizing me. I don't know the answer to that question, to Dan's initial question, but I do think it was hard for me to, when I'm looking at a drug that has $140 million in impact to the system and comparing that to one that has 14 million, and then finding a difference between, each of these, which have relatively similar, sort of much smaller impacts to the system than other drugs that we're reviewing. It was just hard for me to wrap my head around these being the most, costly to the system if we're focusing on cost. And I'm not articulating that well, but I think I'm agreeing with what Dan was trying to say.
Yeah, and again, the process here is just have discussion on how to look at the drugs and determine really back in November where those cost impacts truly lie through the review of the smaller drugs groups. Dr. Burns, I want to recognize your hands up.
Sorry, did you call me? It's hard to hear you, Courtney. I apologize.
I'm sorry. I don't know how much closer I can get to my computer.
I understand.
without stuffing my face in the camera.
It might be me. I keep turning you up and then turning other people down.
Okay.
So, I was just going to agree with what Dan was saying earlier. I don't know the practicality of this, but doing a WAC cost per unit might be the best way to look at some things that, like the Nurtec, where you've got different dosing, different indications. It gets harder though for things like Vipeti, but for the oral medication, sometimes per unit might give you like the best idea of, and that's in the packets, I know, but I'm just saying, like, that's another way to slice it.
Okay.
Yeah, the migraine, I'm sure it's me that's too loud because I'm usually the loud. But the migraine is a weird one because it's got these multiple ways it can be taken. And it may need to be just more flexible because of that.
And again, all this feedback that you're providing, we will be updating these packets with that so that they're, when you can continue to review them throughout this process until, you're ready to make a decision on your 9 drugs. I think it's just important for the board to have a discussion about the initial kind of setup, which we've talked about quite a bit today, and then how like the variants of looking at the drugs, and then also providing staff with the feedback on how to improve any of the processes. So the material packet and the data or the dashboard can be utilized in a meaningful way to help with any decision making later on. So is there any other, we have a handful of other ways to look at these drugs. Let's see, let me clear this off. So this view is the paid per claim by the subset. So again, you're looking more at payer and enrollee, not so much patient out of pocket. I believe patient out of pocket, if also within plan design, how some of these drugs equate to how, oh, I'm sorry, Lori, I just saw your hand up. Go ahead, Lori.
The only other thing I wanted to bring up in terms of another element of cost is looking at the PA requirements and the percentage of approval and the cost that goes out in the healthcare system with that.
Yeah, I think that's more easily identified in the packets themselves. Do you want me to go over to any of the packets and compare? I don't know if I have anything on the dashboard, but that's a good point.
Yeah, I didn't see PA related stuff on the dashboard,
Well,
Courtney, at least.
Yeah, because I think all I see is provider administered step therapy.
We can pull up that section of the packet and discuss it right now if we.
Well, especially with the migraine medicines, many of them require PAs. And so I think it is kind of an important piece of looking at them.
Let me. Apologize for the flipping.
I'm looking for it right now too, Courtney, in the packet. So we'll see who gets there first.
So for this drug, this is Emgality. Oh no, that's the Cardiovascular. I think it's down. Hold, please. All right. All right, so what you're looking at is percentage of approved, prior authorized. So you have about 59% that had the prior author approved. You had 41.2 that were denied. Percentage of plans where the drug is on a non-preferred, so this is considered a non-preferred drug, is 86. And where the plan was completely excluded the drug was 1. Versus the drug being on the preferred, but all of them required for this drug, specifically the therapeutic prior authorization for it. So I'm going to go back up to the top to Ajovy. Hold on. Yeah. So for Ajovy, similar. So you had almost all the plans require it to be a prior authorization. It's about the same number for preferred and non-preferred. So, and I do believe that this is one of those classes where most of them did require a prior.
And that does lead to Dr. Hartong's reference about, triptans as likely being the possibly one of the first lines of treatment for the on-plan design.
Yeah, that would probably be captured then if they had to do a step therapy, or if the prescriber just went straight to the triptans to prescribe. Dr. Burns, that's your hand.
Yeah, so when you're talking about the preventative CGRP agents, usually plans are looking for something like propranolol or topiramate, generic medications that have been used for many, many years for preventative use. Maybe triptans, but those are really abortive therapies, so that would be more likely you would see that with like a Ubrelvy or something like that. I'm not surprised at all by the data call information about prior authorizations for these medications. They're pretty expensive, so that doesn't surprise me.
Thanks for that clarification, Dr. Burns. And yeah, so from what I'm seeing, most of the migraine products are on the non-preferred formulary and require prior authorization. So, which again, kind of can be either an access issue for those that need it, as Lori was kind of pointing out. That's one way to look at it. Was there anything else that I can show the board either through the packet or the data, the dashboard? Let me set this one up real quick. So this perspective again is back to the plan design. I don't know how the board prefers to utilize this information, but individual seems to pay more on the market, or yeah, so individual out-of-pocket costs are often higher. Dr. Hartung.
Yeah, so it wasn't, I was kind of, so this comes from the data call stuff, and so there was, yeah, that was one thing that seemed to be striking, was there was quite a bit of variation in out-of-pocket cost across these different categories in the data call, individual, large group, small group. And then I was wondering, what are the differences between the, other than the descriptive titles that they have, there was no like key about like, is the individual, is that are those Affordable Care Act, just individual plans that people are purchasing? What's large group, what's small group? Are they is like one a high deductible type plan, or one largely high deductible plan? So it seemed to me that there were structural differences about those plans that led to those vastly different out-of-pocket costs for employees or for enrollees. And I don't know if that level of granularity is helpful for us. The large, small, and individual group, from the APAC, we have just total out-of-pocket, average out-of-pocket for the entire commercial segment. So I don't know. It's one of those things that, again, I'm not clear. It's not clear to me that level of granularity is helpful from the data call.
Is there another way, short of just the total of it in the overall summary, Dr. Hartung?
Well, so when we're talking about out of pocket, I'm starting to coalesce around the idea of just using APAC, and then absolutely making sure we're not blending Medicaid into the rest of it, because Medicaid is just going to like drop the average down, because the out-of-pocket costs for Medicaid enrollees are often zero. So just like being careful about presenting APAC out of pocket in a careful way. Again, that doesn't just lump in Medicaid with the rest of the payers.
Yeah. And we can, especially on the dashboard, we can drill out that kind of information specifically if you want Medicaid removed.
Right. No, I realize the dashboards help, a wealth of information. I was just talking more about the reports.
Okay. So going forward, do you not want staff to include Medicaid information, since, like you said, there is often showing zero cost to out of pocket?
I just think it needs to be carved out of the, and I think you've done that in certain places, but it just needs to be carved out of the overall out of pocket estimate where we present it. So we just have Medicare out of pocket, commercial out of pocket.
Okay. The only thing, yeah, that's easy to do because it's just this.
But in terms of total health system costs, obviously that's important to consider when we have Medicaid, Medicare, commercial.
Okay. Get it. Chair Bailey, see your hand up.
So, I mean, I agree, or, kind of with the perspective, it seems like we're headed with kind of looking at APAC as the kind of greater umbrella. But to the extent that it's achievable with staff time and things, I don't want to lose sight of the fact that after we're looking at things maybe globally from APAC and being mindful of Medicaid, I wouldn't want to delete the Medicaid data. I think it's important, and I don't think that's what Dr. Hartung was suggesting either. No. But I don't want to lose sight of, I mean, for Oregonians and all those kind of watching us, large group versus kind of smaller group and things, maybe this class of drugs we're not seeing as big a deltas as some, but in some of the class of drugs we're seeing massive deltas, and I think that's really important to shine light on as we go through our work as a board. So I wouldn't want to lump them together unless it is, I mean, if it is a significant amount of staff effort, then maybe that's a discussion to be had. And I understand it's not going to maybe drive the primary part of our discussion, but I certainly don't want to lose sight of it. But I agree with what Dr. Hartung and Dr. Burns have referenced around maybe having APAC as our broader umbrella, and then we kind of refer back to DPT as we're looking at these with the lens, if that's what I'm hearing my colleagues reference.
But I appreciate the conversation. Is there anything else that the board would like to talk about regarding this therapeutic drug? Or Chair Bailey, do you want to try to go into public?
Yeah, I didn't want to lose sight that we do have for 2 of the 4 drugs in this therapeutic class, we do have letters that I need to reference as well as speakers who signed up. So wasn't trying to cut our discussion on it short. I just wanted to add the time and space for those individuals.
Okay. Yeah, Dr. Hartung, I see your hand up.
Yeah, we didn't, speaking of, we haven't really touched on the survey data. I have two things to note, actually. The survey data that's in here from the patients and stakeholders, I thought that was very insightful, especially the quotes and stuff that was just dropped in there. That was almost like the best, sometimes the best part of the reports. And less so the quantification of the surveys, like sometimes, like, yeah, go to that figure. I mean, I didn't, it just seems almost useless. Like there's like four gigantic blocks there. And so, but like the quotes below it are really helpful and like, and nice to read. And so like just kind of more of just dropping, if at all possible, dropping in just the raw data and the raw comments from these drugs, I think goes a long way versus trying to, like, you know, we're trying to quantify this data that's real messy and oftentimes real sparse and not going to look pretty in a pie chart or a bar graph or whatever. So that's comment 1. Comment 2 is, I just want to highlight, it was brought up in public comment, these errors. And I also noted these issues about net cost. Sometimes in the net cost, gross cost thing, there would be some weird discrepancies where the net cost was higher than the gross cost, which caught my eye. And then these math errors in tables, and some of the tables where there are things that should be added that weren't added together, that weren't or things that were added that shouldn't be added, that need to be fixed as well. And there may be other errors too, but those are the ones that just like I flag. Yeah, table 3, table 4, those summative totals are not correct, where you can't just add the averages together. You need to take that total 7.4 million divided by the total number of enrollees to get the average cost per enrollee.
Gotcha. Okay, so Chris, I see your hand up. Thanks.
Yeah, I just wanted to ask, I mean, this is the only day we have to discuss, or dedicated right now to discuss, the migraine meds and the other meds on this list. So I didn't want to know if we wanted to, if there were specific items that we wanted to talk about to like compare and contrast the different migraine items, that one poses greater affordability issues than the other. I mean, are we supposed to be talking about that during this meeting? I know we've had a lot of discussion about things we'd like to see or kind of adjustments to the report, but should we have any conversation? I mean, maybe we can't do it based on some of the stuff that Dan said, but is this the time when we're supposed to be comparing them or having discussions about affordability or cost with each of them?
Well, I think that's what we've been kind of structuring, is.
So is there going to be another meeting where we're actually, like, I don't know, specifically talking about them then? Or because I to the earlier points about time, I just want to make sure we have enough time to really have a good conversation about each one of them.
So no, the intention is not to come back to this group until November, when after review, where you get to vote on the drugs, but it is the intention for the board members to continue to review the information and to bring insight
That's fair.
to board member or to the board member or board meetings to have that discussion for cost impact in November. Again, it's not the intention for the board to put forth a vote that any drug is more, unaffordable right now than any other drug in the therapeutic class or within this group. It's just to get used to the information and then provide feedback to the staff and how to set it up to be more meaningful for each one. And again, this is why Chair Bailey is, we're extending the board meetings to 8 o'clock. So we have more time to discuss these material packets. So if there's something in these packets from this month that want to be continued on for next month, we can have the discussion. We just know that we have to try to have a discussion for each one of the groups of their in the section or the months that they're assigned. Yeah, Dan, I see your hand up. Oh, you're on mute, Dan. Sorry.
I just want to like highlight something based on what Chris said, in that I have the same inclination to just compare and contrast these 4 migraine products, but I think that that's not what we should be doing, because within each drug, we should be thinking about the world of therapeutic alternatives, and they just happen to be, we're talking about them today, all these migraine drugs, but each one I think we should be thinking about individually in terms of its cost impact and with respect to the overall landscape of drugs that could be possibly alternatives. And so like when we get to Entresto, heart failure, well, there's, a dozen different drugs that are for chronic heart failure. And obviously there's differences, but so I think we should just avoid the temptation to compare these 4 products for a migraine.
That's helpful. Thanks, Dan. And a good point.
All right. Well, if the board has no other feedback regarding the migraine stuff, Chair Bailey, did you want to provide the opportunity for public comments? And then maybe we can spend a little time on the other 2 to wrap up the rest of the day.
Yes, if you can hear me, that is my intention. So there were 4 products in this class, I believe, that we've been referencing today. We did not receive any letters or requests to speak for the drug Ajovy, nor did we receive any letters or requests to speak specifically for this meeting related to Ubrelvy. But we did receive letters as well as requests to speak on 2 of the drugs. So regarding Emgality, we did receive 1 letter from Cynthia Ransom from Eli Lilly. So that letter is available on the board website. And then we did receive 4 letters related to the manufacturer Nurtec. So the letters that we received were from Tom Brownlee from Pfizer. There were 2 letters received related to that. From Ms. Dresden Skis Gregory, PhD candidate, principal and CEO of Sustainable Environmental Services, as well as we received a letter from Katie Lukings, a public school teacher. So those have been included in the board packet, as well as they're posted on the board website. And the names are before us here today. We also did receive 1 request to speak from David Gross from Pfizer. So if David is here, I would like to welcome David and provide him with an opportunity to speak.
Thank you. Can you hear me okay?
We can. Welcome.
Great, thank you. Appreciate you allowing me this time, and I'll be brief. I just want to update you with a couple things. So my name is Dave Gross, and I'm from Medical Affairs with Pfizer, and here to provide you some information regarding Nurtec, which, as you guys have discussed, is approved for both the acute treatment of migraine with or without aura, and for preventative treatment of episodic migraine. And so I appreciate the comments that were going back and forth about the cost per claim. It really makes a difference if you're taking it routinely versus as needed for the acute therapy. And as you see, that it's the only oral CGRP that actually is approved for both indications. So the one important update that I wanted to make you aware of is that recently the American Headache Society published a position statement on the use of CGRP targeting therapies for the prevention of migraine based upon our review of the available evidence for the efficacy and safety of these medications. The American Headache Society notes that there is substantial cumulative evidence supporting the efficacy, tolerability, and safety profiles for CGRP targeting therapies for migraine prevention, and concludes that these CGRP targeting therapies such as Nurtec should be considered as a first-line option for migraine prevention without a requirement for prior failure of other classes of non-specific preventative medications. And I know it's not the role of this board to make coverage decisions necessarily. That's left up to the P&T committees for the commercial plans and for Medicaid and et cetera. But just wanted to give that information to you that the large American Headache Society has made these recent recommendations. I would also like to point out that Nurtec itself is not covered, or it's not on the preferred list for Medicaid. It is on numerous commercial plans, but it does have a prior authorization and a step edit to be approved for the Medicaid population. So, and Dr. Burns, I wanted to answer your question. Zavspret, the drug that you weren't familiar with, is a CGRP. It's a nasal inhaler for acute treatment. Thank you for your time and appreciate it.
Thank you for being here. During this time, I do know board members also can ask questions of the speakers if they have any questions. So Mr. Gross, if you're open to it, I would like to just open the floor if any board members have any questions for yourself related to the information that you just shared. Do any board members have any questions? All right, without questions, thank you, Mr. Gross, for being here today.
Oh, I'm sorry, Shelley. I see Lori's hand is
Oh,
up.
my apologies. I didn't see that. Ms. Hoagland, you have the floor, and if Mr. Gross is still here to answer the question, welcome that dialogue.
So my question is, at this point, I know that the use of this medicine for acute pain is more recent than prevention. And I just wondered, in terms of patients, what they're being prescribed. Is it becoming very commonplace? Do patients use it for both? You know, kind of the prescribing behavior of this medicine.
Yes, I don't have the exact numbers, but it is being used for both. Although generally it's not recommended. So oftentimes people that are on preventative treatment still have some breakthrough migraines where they need to use an acute treatment. But the package insert indicates, so with Nurtec, for preventative treatment, it's 75 milligrams every other day. And so it's recommended not to take more than 75 milligrams in a 24-hour period. So I'm just going by the package insert. If it happens to be that you have a breakthrough migraine on the day that you took the preventative treatment, it's not recommended to take that again. But if it's one of the off days, you could possibly, or take another acute treatment in addition to taking the chronic Nurtec. So it's being used for both. And I can't tell you which is more. I would assume that more people are on the acute treatment. Because most plans make you, for preventative, you have to try and fail at least a couple, like a propranolol or an anti-epileptic, which are drugs that are used for preventative treatment for years. But that's why I brought to your attention the American Headache Society recommendations that for preventative treatment, they recommend that the CGRPs in general should be a first-line treatment rather than a secondary. Hope that answers your question.
It does. Thank you.
Do any other board members have any additional questions of Mr. Gross? Mr. Gross, thank you for being here today. Courtney, you have the floor.
Thank you, Chair Bailey. I think going back, we had a really great conversation regarding the migraine products. There is a public comment for Vraylar, so I'd like to spend just a couple minutes for the board to discuss Vraylar, even though we started the day just chatting about it, and then provide that individual to give their public testimony. Is there any other comments, feedbacks, or suggestions on how the board wants to look at Vraylar? And I can share. Oh, no, just sharing. Around Vraylar, or is there any concerns with the cost or any additional information that the board would like for this drug? I guess hearing none, Chair Bailey, did you want to provide the public speaker the opportunity?
Yes, absolutely. Sorry, I was looking at some of the comparable products to Vraylar and just kind of reviewing that myself personally. But I do want to reference that we did receive one letter and one request to speak related to Vraylar. The letter and the request to speak were both provided by Lauren Sant from the Carrier Ambassadors Program. So Lauren, if you are here, welcome, and you have the floor.
Thank you, Chair Bailey. I think I said this before in my testimony, just to really be thoughtful in looking at the number of Medicaid patients that are on Vraylar. And it is definitely my experience that the Oregon Health Plan doesn't pay for things that don't work and don't save money in the healthcare system. And so perhaps looking at that utilization as an indication that this is a drug that's really needed for that population, and not interfering with the patient-provider decision on what's the best drug for people with schizophrenia. Thank you.
Thank you for being here today. Courtney, while we didn't have requests to speak related to Entresto, I know we still have time left in our meeting today, but I do also want to make sure before the end of the meeting, we acknowledge the letters that we received for Entresto, because certainly those were provided in our packets as well.
Yeah, and I do think we should probably just do a high level touch base around the drug, since we spent time with the other drug.
And one additional thing I guess I did want to reference is I know in the board packet, we did kind of reference our discussion related to cost and affordability. I missed it in outlining it specifically in the meeting guide. So I also do want to make sure we ask board members if they have anything additional they want to add to that. I know I did a couple calls for it, but I blended it kind of within the initial section when we were discussing Vraylar, but I don't want to lose sight of it for the record that we're having that discussion as a board. And I certainly, if any board members have more to add today related to it, I do want to make sure that we're documenting that and having that discussion, but also of course, having a broad discussion related to Entresto.
I guess hearing none, I'm going to share my screen again so we can kind of talk about the one thing I just want the board to be mindful of with Entresto is it does not have a therapeutic equivalent or alternative or bio to it. So the cost presented, there's nothing to really compare the cost impact short of just what is presented in APAC and the data call. So this may be a slightly different drug to consider because it's the only one I believe that does not have any sort of therapeutic equivalent or alternative to it. I guess it's kind of flipping through. These were the NDCs that were used. Looking at overall impact. So if we're looking at APAC spend 51.2 mil versus 6 million on the total spend. I'm not sure if there's any specific numbers that the board would like to consider or look at. And again, with the APAC, the total number of enrollees is based off of reporting of Medicaid, Medicare, and the commercial, and all of health system or health carriers, not just the 11 that reported into the data call. So that number again is going to be quite significantly different than it is. So that gives you the more overarching what's happening within the healthcare system in Oregon versus just the 11 reported carriers under the data call, which reported only 1,711 enrollees for the drug. But even at that, the data call enrollee paid still showed a pretty significant impact for a patient out-of-pocket cost. Is there any other information that the board members are interested in looking at within the data call, or I can go over to the material packet and we can discuss anything in there? Otherwise, we can just keep it at a high level and then the board can continue to review these packets and the information as staff updates them. Dr. Hartong, I see your hand up.
I think it like one thing that makes this one unique, as well as Vraylar to some extent, is that there aren't any, you know, there's not a whole field of drugs that are very similar. There's no alternatives, as you say, all those other treatments for heart failure, and this falls in line with other treatments for heart failure. But like if you know the data call, I noted that the price concession for Entresto is like 11.5%. So which I think is significantly less than we had looked at the migraine products, which are in the, you know, mid 20s to one of them had a price concession of 41.2%. So this is a substantially lower price concession. Same thing for Vraylar, very small price concession, which I think reflects like just the competitive environment of these drugs. So again, something to consider, like with the utility of the data call, what information we can get out of it. And I feel like Entresto is they're not getting good rebates relative to the other drugs we've looked at.
That's a good observation, Dr. Hardong. Any other feedback from board members or insights that they've picked up for the review of the packets or the dashboard? Again, apologies for the quick scrolling. I wanted to see this one.
One on page 16 of the packet, I mean, one thing that jumped out to me, you know, again, appreciating that we're doing maybe kind of keeping APAC at the high level before we drill down into the DPT, is, you know, the average out of pocket per enrollee, very, very different on the small group versus, you know, or kind of the large group versus individual, or, you know, it just, again, that's plan design from my perspective, but I mean, from a patient out of pocket, 740 versus 308. You know, so depending on, you know, what type of employer you have, what type of job you have, I mean, look at how meaningful that is. It's more than twice as much. And again, from my perspective, I think that's more a reflection of plan design, but certainly something that jumped out at me.
Thank you, Chair Bailey. So just to point out, again, Medicaid CCOs also, so the fee for service, it was not reported on their top 40 quarterly reports in 2023, but they did have the Medicaid CCOs reported it as one of their top 50 spends. And then captured the year-over-year price impact from 2022 to 2023. Even though it was only 0.2%, it was still reported as one of their more significant year-over-year increases. And Dr. Hartung, I see your hand up. Oh, you're on mute, sir.
Since we're on this section of the report, I don't find this particularly useful because it seems to be redundant with the APAC reporting of, you know, APAC reports Medicaid as well. And so this is kind of just summary data from the derm group at OSU, which I know about. And so like this is a section I feel like we could get rid of, and I'm pretty sure this section is not in the rules and regs about what we need to report. So
it is just associated with the health insurance. So if Medicaid and Medicare are considered a state, you know, an insurance plan in the state, that's why it's included.
Not the entire section, but these tables about this thing, the fee for service, CCO, like it's this information is in the APAC summary data that's reported in multiple other tables. so I think that this is I found it less useful. And like, again, just with the point of like stripping away stuff that's not as relevant. Just since we're here, I wanted to bring it up because I have a note in my document that not useful.
It'll save us some time to look up the steps we have to go into each report and do the analysis. So, but I do, before the staff just removes it, I do want to see if there's any other feedback from board members on if anything regarding the Medicaid gross amounts are impactful for their understanding of cost to the healthcare system. Otherwise, it is available online through the Durham reports that Dr. Hartung was just mentioning. Otherwise, staff is happy to not include it and save us some time with the rest of the materials. Laura, I see your hand up.
I think it's important to include it when we have it available. It does shed light on, an important part of the state cost.
Okay. But if it doesn't, like if it shows up no information under quarter 1 through 4, then just keep it out of the material packets.
But so I just want to note that like table 3 has got it's in APAC. The Medicaid spending is in APAC. And so this is just a different reporting mechanism of the same data. So we have commercial, Medicaid, Medicare, 2023, 8.8 million in Medicaid on this drug. Mm-hmm. And so I assume that's pretty, in this report, it has it's slightly different, 8.22 million, according to this this analysis, which that's just the CCO. So there's a probably small sliver that's in the fee for service open car that makes up the rest of that. So again, just like, I just want to be clear that I'm not saying we not consider Medicaid, but just this high level summary, this way it's presented here.
Yeah, I understand and I agree. I just want to make sure that the rest of the board members understand that it is captured in the reporting through this number here. And it's probably even, and again, the numbers here are just specifically for the Medicaid CCOs.
It is interesting. I will just looking at this now. I'm sorry to but spending in Medicaid went up from 5 to 8 million in 1 year. So there was a pretty sizable increase, which I think, to the point I made earlier about having trend data, having multiple years of APAC, I think is provides another kind of angle to look at things.
So this is one of the only drugs that showed up on the year-over-year charge spend, the increase. I'm pretty sure this is the only drug that we have that came up on this report. So if by chance any of the other drugs are, then I'm happy to keep it in because it does show a price trend. But not every drug that the board is reviewing has the same information because not all the drugs showed up on the CCO or sorry, the Medicaid most costly or most expensive drugs. So, but if it does, I'm happy to include it how I did here. Otherwise, I'm happy to save staff some time and not having to go into put this, generic boxing stuff in just to provide the information. Anything else regarding Entresto that the board would like to see or discuss, whether it's in the material packet or in the dashboard? You guys have mastered all the review process? You ready for next month's? All right, I guess then Chair Bailey, I'm going to take all the suggestions that were provided to staff. Dr. Hartung, I did appreciate your willingness to work with us a lot more clearly, closely as staff to set up the next review packet. So I will be reaching out to hopefully have a conversation just to make sure that these packets are as meaningful as possible for the reviews. And staff will start setting up the second group for next month's material information, and then update these packets into a new version with the additional updates as well. Is there anything else that board members would like staff to do before we close out the discussion for group 1? Chair Bailey, I see your hand up.
Yeah, just wanted to reference the letters we received, and also wanted to reinforce that because we're not voting on these until the end of the year, additional information that we receive, we can still include those kind of in packets. So if we receive information, whether that's public comment in any way, like all that information will still be additive towards the end of the year when we're voting on these. So I would still encourage anyone with additional information that they want to share to the board to continue to provide it. And the only deadline related to that would be the deadline in November that we have before the meeting that we have this discussion on. Is that accurate, Courtney?
Yeah, it's accurate. These are rolling reports.
Yes.
So they're working reports throughout the month, and the significant discussions will come in November, hopefully with the board understanding of what drugs actually can be perceived to make the most challenge in the healthcare system or patient out-of-pocket costs. So we have a couple months to really fine-tune the discussions and review process.
Thank you for reinforcing that. I just want to reinforce it for the public as well as for my colleagues here today, that these will continue to be iterative to an extent, and that the information will be included. So, but I did want to reference that we did receive 3 letters related to Entresto that are published on the board's website, and they were also included in the packet. Those letters were from Alyssa Patel from Novartis, Courtney Piron from Novartis, Sarah Hoffman from the Partnership to Advance Cardiovascular Health. So just wanted to reference for the record that we did receive those letters, and they are available in the material packets.
And Shelley, Lori's hand is up. Just
Ms. Hoagland, my apologies for not seeing that. You have the floor.
I just wanted to express my appreciation to having information in the packets that sheds light on barriers to care. I think that's not something we have any necessarily control over, but I think it's an important piece when we're looking at affordability. Thank you.
Ms. Hoagland, thank you for sharing that. And to piggyback on that comment, I also found the additional information related to 340B and the potential impact or kind of the revenues that are associated with those drugs and their link to covered entities and how that may impact them. I appreciated that additional information as well. So thank you to staff for all the additional work you've made on this year's packets versus last year's packets.
all right. You're very welcome, Chair Bailey, and thank you, staff or board members, for all your help. Staff has worked really, really hard to get these set up for you, and I look forward to continuing to work with you to make these reviews as meaningful as possible. So see you next month.
No, absolutely. Well, thank you. And I do want to reference as a reminder, our next board meeting is August 20th, 2025. And again, for my colleagues on the board here, as well as for everyone listening today, please do adjust your calendars as the meetings will start at 8 a.m. Pacific. They will still adjourn at noon Pacific. So with there being no further business before the board, all in favor of adjourning the meeting, please say yes. Yes.
Yes.
Yes.
Any opposed, please say no. All right, meeting is adjourned. Thank you, everybody.